Okay, so if you're deep into endo prep right now, or maybe just starting out in practice, you definitely know the main challenge isn't always that big main root canal, right? It's often that microscopic maze hidden off to the side, getting that anatomy clean. Well, that's really the make or break point for long-term success, isn't it? Because that's where infections love to hide.
Absolutely, and that's exactly why we're diving into this today. We want to cut through, all the complex research and give you a really practical clinical summary for handling those accessory and lateral canals.
Yeah.
They're notoriously tricky, and honestly, they're often where biofilm lingers, compromising even the best main canal prep.
Yeah, we've got some great sources lined up. So here's the plan. First, let's get those definitions down cold. What are these hidden spaces and what are the risks? Then we'll get into the nitty-gritty of cleaning and irrigation, especially focusing on where things can go wrong chemically. And finally, we'll look at filling strategies, the obturation part, that give you the best shot at sealing everything up properly, three-dimensionally. Okay, let's start with the basics then, because sometimes the terms get a bit jumbled. What's the real difference between an accessory canal and a lateral canal?
Good question. It really boils down to location. Generally, we talk about accessory canals as these little branches off the main canal. They connect directly out to the periodontal ligament, the PDL. Usually you find these mostly down in the apical third near the root tip. And an apical delta, that's just a really complex network of these accessory canals right at the apex.
Got it. So apical delta is just a bunch of accessory canals at the tip. What about lateral canals then?
All right, so lateral canals are technically a type of accessory canal, but we define them specifically by where they are. They branch off higher up in the coronal or more commonly, the middle third of the root. They often run kind of perpendicular or maybe diagonally to the main canal. And knowing this difference matters clinically because of what tissue they're exiting into.
And okay, why all the fuss? Why do we spend so much time worrying about these tiny little side channels that are often, smaller than even a small file?
Well, the clinical impact is huge. Think of them as tiny pipelines. Bacteria, toxins, all that nasty stuff from a dead pulp can travel through these ramifications straight out to the tissues around the root. So this means infection, periodontitis, isn't just limited to the apex. You can get lesions anywhere along the side of the root or even in the furcation area of molars if a canal happens to exit there. And what's really interesting or maybe challenging is just how common they are. These aren't rare flukes. They're a pretty standard part of root canal systems. Our sources show they show up in a really significant chunk of teeth studies report numbers like 27% all the way up to nearly 60%.
Wow, 60%. That's
Yeah.
that's massive.
Right.
So basically, in more than half your cases, you just have to assume this complex anatomy is working there.
Exactly. You have to assume it's there. And while they can pop up anywhere, accessory canals are most common down in that apical third. Some studies say as high as 73% of all these branches are apical. But diagnostically speaking, if you see a clear, sort of isolated dark spot, a radiolucency on the side of the root on an x-ray, that's a big clue and often points towards a lateral canal exiting in that middle third.
Which brings us to diagnosis. We lean so heavily on our regular x-rays, but they don't always show these, do they? You mentioned advanced imaging helps, but there's a catch.
Yeah, they're really tough to spot beforehand on standard 2D films. Lateral canals, rarely visible. So the diagnosis is often presumptive, based on clinical signs like that localized thickening of the PDL you might see. Now, advanced imaging like cone beam CT, CBCT, it's definitely helpful for seeing the overall 3D picture, the complex anatomy, but it has limits. Our sources point out CBCT isn't really effective for telling you if you can actually get into the canal physically. It shows you it exists, sure, but not if it's negotiable, not if you can actually instrument it.
Okay, so if diagnosis is often a best guess, we just have to act like the complexity is there and our cleaning game has to be top-notch. Let's shift gears then to the chemical side of things, how we actually eliminate that hidden biofilm. We know after we shape the canal mechanically, we create that smear layer. That's the big hurdle, right?
Oh, the smear layer is definitely the enemy, especially in these complex systems. Every time you use an instrument, it creates this coating. It's mostly grinding debris, dentin dust, bits of pulp tissue, and this layer basically acts like spackle. It plugs up the openings to lateral canals and dental tubules, and it completely blocks your irrigants from getting in there and doing their job. It stops disinfection cold.
So to beat it, we need like a 1-2 punch chemically, right? What's the absolute must-do protocol?
It definitely requires that dual approach because the smear layer itself has both organic stuff and inorganic stuff. So first, you absolutely need sodium hypochlorite, NaOCl, usually 2.5% or 5.25%. NaOCl is key for killing microbes, obviously, but also critically for dissolving the organic bit, any leftover pulp tissue, and the organic part of the smear layer itself.
And because the NaOCl doesn't really touch the hard inorganic dentin chips.
Exactly. It can't dissolve the mineralized part, so you have to follow up or alternate with a decalcifying agent. Typically, that's 17% EDTA. EDTA is a chelator. It grabs onto the calcium in the inorganic debris and pulls it out, dissolving that part of the smear layer. Studies really back this up using AOCL and EDTA. Either alternating or sometimes mixed is the best way to remove that smear layer, especially higher up in the cervical and middle parts of the root.
Okay, that brings up a really important clinical question, especially for students maybe feeling rushed. What about time? How long do these chemicals actually need to sit in the canal to work effectively?
That's a great point, and it's often overlooked. Chemical reactions take time, right? EDTA works relatively fast on the inorganic layer, but NaCl needs sufficient contact time to really break down that organic tissue effectively. So generally, you want to keep fresh NaOCla in the canal throughout your shaping process. Then, for the EDTA step, you're looking at a dedicated soak time, often recommended around 60 seconds. And critically, follow that with a final flush of NaOCl to wash everything out and neutralize things. If you skimp on these times, you're essentially leaving those lateral canals plugged up.
Okay, now let's hit the tough part, the limitation we found in the research, the apical third. If NaOCl and EDTA work pretty well in the top and middle, where does the chemistry kind of fail us?
Yeah, this is where we run into a real clinical challenge. The research is pretty consistent here. Regardless of the specific irrigation technique you use, none of them were found to be reliably effective at removing the smear layer way down in the apical third of the canal system.
Why? Why does it suddenly stop working down there where we arguably need it the most?
It's a mix of anatomy and, well, physics. First off, the canal is just physically much smaller down there, which restricts fluid flow naturally. But second, and this is really crucial, we run into something called vapor lock. When you try to push irrigant down with a needle, it's really hard to displace the air or gas trapped at the very tip in that apical constriction. The irrigant literally can't reach the surface to react. Your needle often stops short, maybe a few millimeters, and boom, you lose your cleaning power right in that critical zone.
Wow. Okay, so if we know the chemistry isn't reliable apically, does that change how we think about shaping? Does it mean we actually need to enlarge the apex more than maybe we used to think just to compensate?
Absolutely. Yeah. It shifts the burden back towards mechanical preparation to make up for that lack of chemical efficacy down deep. Older ideas sometimes favored minimal apical shaping, right? But current thinking suggests you really need to open that apex up enough, often to something like a size 30 or 35 file with a 0.04 taper, specifically so you can get your irrigation needle closer to the actual working length. Ideally, you want that needle tip within maybe 1 to 2 millimeters of the apex to allow for better fluid exchange and minimize that vapor lock effect.
That focus on shaping for delivery is so important. Okay, so if we can't physically touch a lateral canal and chemistry struggles apically, we need something else to help move the fluid sideways, right?
Yeah.
This is where those extra techniques come in.
Precisely. You need to get those fluids moving dynamically. That's where supplemental techniques like passive ultrasonic irrigation or PUI come into play. Using ultrasonics creates this acoustic streaming, these microcurrents in the irrigant. It basically vibrates the fluid intensely, pushing it into all those little nooks and crannies like lateral canals that the needle itself just can't reach. It really boosts the cleaning effect.
Makes sense. Okay, let's pivot now to managing the case after cleaning and getting ready to fill, focusing on takeaways for, the newer dentists listening. After cleaning, we often place medication inside the canal. What's the big warning sign we need to remember about calcium hydroxide?
Oh, this is a classic mistake. I've seen it happen. Calcium hydroxide, KOH2, is standard for disinfection between appointments, right? But you have to be incredibly thorough when removing it. Here's the clinical warning. Research clearly shows that leaving behind KOH2 remnants, even small amounts, significantly blocks the penetration of your filling material, your sealer in gutta percha, into lateral canals.
So if that chalky stuff is physically plugging the entrance, nothing's getting in to seal it, no matter how good your obturation technique is. That could definitely lead to failure down the road.
Exactly. It acts like a physical plug. So again, meticulous irrigation, maybe even using ultrasonics, again, specifically to dislodge those remnants, is absolutely critical before you start your final fill.
Right. So assuming we've got it clean, when it comes to actually filling the canal system, that three-dimensional seal is the goal. If we're trying to push sealer and gutta percha out laterally into those accessory canals, which techniques actually give us the best odds?
For getting that lateral fill, the evidence points strongly towards warm techniques. Thermoplasticized gutta-percha methods, things like warm vertical compaction, or maybe some hybrid techniques consistently fill more simulated lateral canals compared to cold methods, compared to just standard cold lateral condensation.
And why is warm better? What's the mechanism there?
It really comes down to the flow and the pressure. With warm techniques, you're heating the gutta-percha, making it soft and flowable, and then you're applying significant compaction force vertically. That heat and pressure combination forces the sealer and sometimes even the softened gutta-percha itself out laterally into those tiny ramifications. It just flows better, especially in the middle and coronal parts of the root.
That makes total sense clinically. But okay, if warm compaction is clearly better for 3D fill, why do so many schools or practices still teach or rely heavily on just cold lateral condensation? Is it just the complexity or the cost?
Yeah, that's the practical side of it. Cold lateral is definitely simpler technically, requires less specialized equipment, so it's often the default, especially maybe in general practice settings or older training programs. But, for the young dentist who's really aiming for the best possible outcome, the research is pretty clear. If you want to maximize your chances of sealing that lateral anatomy, incorporating warm compaction techniques is the way to go. It involves a bit more chair time, maybe a steeper learning curve, but it likely pays off in terms of long-term success rate. It's a trade-off.
Understood. Okay, one last specific scenario. Actually getting a file into a lateral canal. We've mostly said they're too small, but there are exceptions, right? It can happen.
It's definitely the exception, not the rule, and mostly you see it in case reports. But yes, there are rare instances where a very small hand file, like a size 10K file, might just happen to slip into a patent open lateral canal. Sometimes it's intentional if you see it clearly. Sometimes it's just fortuitous. It typically happens when the main canal is pretty straight and the lateral canal branches off nicely in the middle third, where access is a bit better.
Okay, but big caution sign here for everyone listening. You probably shouldn't be actively trying this unless you have very clear radiographic evidence of a wide accessible canal, right? Because forcing it could cause major problems like ledging or perforation. But if you manage to get in there, what's the big advantage?
The advantage is huge. If you can actually get mechanical negotiation, even if you just slightly enlarge that lateral canal, you allow for way better irrigant penetration and disinfection than chemistry alone could ever achieve in that specific spot. And this seems to correlate really well with successful healing, both clinically and on x-rays, especially in those tricky cases that started out with a clear lateral lesion, that lateral periodontitis. You're essentially turning it from just a chemical cleaning challenge into a combined chemical and mechanical one for that specific branch.
Wow, okay. This has been incredibly useful, a real deep dive into mastering that often invisible anatomy. Let's quickly wrap up with the absolute key takeaways for every dental student or young dentist listening.
Okay, takeaway number one, respect the hidden anatomy. Assume those lateral canals and apical deltas are there, because they often are, and they're major culprits in treatment failure. Second, maximize your chemical cleaning. Use that AOCL and EDTA alternation religiously, give them enough time to work. But critically, understand the limitations, especially the irrigation challenge in the apical third due to vapor lock.
Third, compensate for that apical chemical limitation mechanically. Shape the apex large enough, maybe 30 or 35.04, so you can get your needle close, within 1 millimeters of the tip. Fourth, be super careful about removing all calcium hydroxide remnants before you fill. Don't let that block your seal.
And finally, number five, seriously consider using warm obturation techniques like vertical compaction. They give you the best chance of pushing sealer into those lateral spaces, especially higher up the root. And remember, the ultimate goal is really about eliminating the biofilm load. It's not always about perfectly filling every single microscopic space, even though that's ideal. Clinical success often happens anyway.
Which leads perfectly into our final provocative thought for you to mull over as you go into your clinical work. We know that clinical success, healing, often happens even when we suspect or even know from histology that those tiny lateral canals probably aren't perfectly filled. So what else is going on biologically? What unseen processes are happening in those periapical tissues that allow things to heal up once we get the main canal cleaned out and reduce that overall bacterial load? Maybe it's the host immune response kicking in more effectively. That balance between just enough microbial control in the main canal and the body's own healing capacity, that might be where the real secret to long-term endodontic success actually lies. Something to think about. Thanks for joining us for the deep dive.